undergrad, I decided I wanted to end up going to dental school, so I picked up the HPSP scholarship. That allowed me to go to any college I wanted or any university I wanted to for dental school.
Welcome to Experience Armymedicine interviews. Our mission is to interview local medical professionals within the Army so they can detail their impact in medicine today. Today's interview is with Lieutenant Colonel Mark Serra, 63 November, oral maxillofacial surgeon. He hails from Madigan Army Medical Center from June 30th.
Mark Serra. I'm a 63 November, which is a oral and maxillofacial surgeon. I grew up in Seattle, Washington. My dad was a Army reservist, and so he retired out of the Army as an 06 infantry guy. So I put all my eggs in the basket as a junior, senior in high school to go to the Naval Academy of all places. But they switched my records. I didn't get in the Naval Academy, so then I went to the University of Washington with Navy ROTC. So ended up joining Navy ROTC, did that for a while, then kind of fizzled out, didn't enjoy it as much. In undergrad, I decided I wanted to end up going to dental school, so I picked up the HPSP scholarship. And so that allowed me to go to any college I wanted or any university I wanted to for dental school. And I picked the most expensive one I could go to, so I went to Columbia University in New York City, where from the beginning I wanted to do oral surgery right away, and soon after decided maybe I didn't want to do that. I'm all over the place, as you can tell. Ended up actually applying to pediatric dentistry and orthodontics. And so not until after I graduated dental school did I end up going to an AGD program, which is the one-year AGD program, that I really fell back in love with oral surgery. Most oral maxillofacial surgeons who are not in residency program teaching, they're going to be with a dental activity in primarily doing the dental readiness mission. And so the dental readiness mission means that you're trying to get all of the soldiers ready for deployment. So there's a thing called the class 1, 2, 3, 4. We will typically get patients who are referred to us for class 3, meaning that they have wisdom teeth that need to come out. A typical surgeon who is not in a training program is going to be really supporting that mission of cranking out wisdom teeth, doing dental alveolar surgeries. If they have access to an operating room, so whether they're at a smaller community hospital or just a different hospital that doesn't have educational programs, then they may end up going to the operating room maybe once or twice a month and doing larger cases. And that's up to the surgeon to do that. So when I was at Fort Campbell, I did teach AGD there, so that was right after I graduated, and I taught AGD students there, but my main thing was dental alveolar. I'd probably see 3 or 4 patients in the morning, surgeries, and then in the afternoon I'd just see my consults. And then I think once a week once every 2 weeks I'd do an orthognathic case in the operating room. Or, which is even more fun, I would get to do anesthesia in the operating room. So, just to maintain my skills. Depending on your commander, there are opportunities to moonlight. And it shouldn't necessarily be the thing that drives you to become an oral surgeon in the military, because that's like kind of a conflicting thing. It's like you have to really have your mission, but as long as the mission's going well and the commander supports it, then generally you can do a moonlighting gig. A lot of private practices will allow you to operate after hours, which is kind of cool. And so when I was at Fort Liberty, I would do my educational gig during the day, and then once a week I would do a moonlighting gig, which was great. I mean, it wasn't anything I really needed to do, but it was fun because when you're teaching residents, you don't necessarily get to keep your hands wet, and you don't really get to do this stuff. I've enjoyed every place I've gone to. As a graduate coming straight out of dental school, I was coming from New York City, and I had no idea what the polar opposite of New York City would be until I got my orders to go to Fort Sill, Oklahoma. So I ended up at Fort Sill. I was really upset about it, but that was an incredibly fun year. And I think that if you talk to anybody who's spent more than 4 years in the military or been to multiple places, they're going to say the location is what you make of it. And it's definitely the people. I really liked the first year of the military because it was such a different thing. The most growth I ever had was probably at Fort Bragg, now Fort Liberty, where I'd just come out of fellowship and started teaching. But it was the first time that I was able to operate with surgeons who had trained at other locations. Because before that, it was just me, or it was me at JBLM. But being able to train with and teach with people from Tripler, BAMC, Bragg, and I want to say Gordon at the same time, that was super fun. And just kind of learning how everybody learned something a little bit differently, but it made it a lot more fun. There are different tiers for bonuses that we get, and it's really very, very competitive as far as the tiers. So a non-subspecialty oral maxillofacial surgeon is going to be making more than a subspecialist in ear, nose, and throat surgery. So the bonuses are absolutely there to kind of battle that attrition rate, but I would say the attrition rate within residency, it's maybe 10% in residency. After residency, after payback, after that initial payback, I think that we lose probably another 30% right there. And then like we've been riding this wave since probably 2015 of the senior colonels who stayed in for 35 years, but they're all getting out right now. And so we were pretty dead in the water for a while there with 1 or 2 06s. But now I think last year we just promoted probably 10 lieutenant colonels. So we're back on the upswing. But as far as attrition rate after that initial payback, it probably just trickles off after then. Like kind of if people make it past the year 15 mark, they're in. As a dentist, I think that the Dentax local dental activities, they'll put on their own dental or continuing dental education. For oral maxillofacial surgeons, it's a little bit different because the education can't really come from within the dental activity. It's got to come from higher or I guess broader than that. So what most of the oral surgeons get their CME or CDE from is by going to the annual conference. However, like what we started doing here at JBLM is we do an annual, what we did last year, we did it twice, but we do an annual CE/ICTL course. And so the ICTLs are the individual combat task list. And that's a list created by the consultants and the Surgeon General that lists off the critical wartime skills that a surgeon needs to have to be in the military. And so we put on a cadaver course with lecturers who are generally well known in the civilian world as like top level educators. And so they come in on their own dime and they help educate surgeons from across the entire enterprise, meaning like from here all the way to Fort Bragg. So they, if their command supports it, they can come here, knock out their ICTLs and their 20 annual continuing education credits by just going to that course. But it's a really cool course. It's funny because I remember asking this as a captain to I guess it was a 2-star. I was like, how did you even imagine staying in that long? And they told me something that I didn't think was going to be true, but like it's stuck, and it's really the people. It's your best friends end up staying in, and some of my best friends have gotten out, but the thing that they miss most about being in the military is just the camaraderie of like not having to compete with the guy across the street or like calling somebody for advice because you're in competition with them. Like you have that camaraderie between all the surgeons within the military. So the thing that keeps me happy every day are the people. The people are great. Teaching residents and just working with great assistants and great other surgeons. That's what makes it fun. So I think full exposure to the scope of oral maxillofacial surgery is a very, very important thing. Understanding that it's more than dental alveolar, it's more than doing implants, it's more than maybe what you assume your experience is with oral surgery. Because I think for me, in dental school, all I knew it was taking out teeth. So if you can get exposed to what a full scope oral maxillofacial surgeon does, that's key. If you're in school already, like if you're in dental school and you want to apply to oral surgery, the biggest things I would say are you need to expose yourself to the med school regimen. You need to live the life of a med student and really learn those classes that the med students are paying attention to those first 2 years. And then when the med students are doing their clinicals, that's usually when dental students are doing dental work. You should try to get a rotation in on anesthesia and try to follow either a CRNA anesthesiologist or even a dental anesthesiologist to see if that is something that you would be interested in, because that is really where, when people say, oh wow, there's such a crossover between medicine and dentistry with oral surgery, it's really at the anesthesia level. That's where we're really in the field of medicine. So yeah, I would say you got to do anesthesia. You have to see what that's like. And then the externships are paramount. You have to see what the military residencies are like by spending some time on your own and interviewing at the residencies for at least a week.
Thank you for listening in on our Experience Army Medicine interviews. We hope that these interviews help encourage your own path into a healthcare career. If you enjoyed the interview, please don't forget to like, follow, and share our content as we continue to dive deeper into Army medicine. Be all you can be,